All right. Hello and welcome, everyone. This is Caleb from TASC at the National Rural Health Resource Center. Thank you for joining us. This is the first of the Alternative Payment Models 101 Learning Collaborative. Thank you for joining us. We will get started in just a few minutes with Shannon Calhoun, our subject matter expert. So as you join, please be sure to dial into the audio version of the webinar so you're able to communicate questions and introduce yourself and things like that. Once you do, please be sure to mute your computer speakers, as they'll have an audio feedback loop. And once you join the webinar portion, please take a moment to complete the few polling questions here. We'll utilize this now and then once again at the end of the Learning Collaborative to help demonstrate just a change in knowledge and understanding and familiarity with the advanced payment models. What else do I need to make as far as disclaimers? So again, this will be a 6-part webinar-based learning collaborative where we'll have some homework and some education activities, and really what we want to do is provide some basic understandings about advanced or alternative payment models. And to do that, we've partnered with Shannon Calhoun, a distinguished healthcare executive with over 24 years of experience in the industry. She's a leader of collaboration and collaboratives that develop strong relationships and has expertise in leading healthcare provider collaborations, speaking and engaging with leading providers in transformation, building healthcare networks. She served as the Vice President of Network Development at the National Rural Accountable Care Consortium, a Transforming Clinical Practice Initiative grantee of the Centers for Medicare and Medicare, so CMMI initiative. She's also served as Vice President of Business Development for Caravan Health, a national leader in the transformation and implementation of innovative healthcare models for supporting quality, cost-effectiveness, and health promotion. So we are very excited to partner with Shannon with the extensive background and experience that she has in the transition to value, both working with healthcare entities such as hospitals and CEOs, as well as on the ACO side of things. So we're very excited to have Shannon. And another thing to note, we do have a website that we've created for the Learning Collaborative. So if you're unable to participate in a live webinar and discussion, we will have these are being recorded, the webinars are being recorded and will be posted to the external SharePoint, which is what we're calling the external website. The external SharePoint, the recordings will be posted. There's a forum there to ask questions, to participate in any of the homework assignments and things like that. So when we're sending out notices and emails and resources will be posted there, things like that. That's where all of these things will be kind of hosted for us. And during the webinar, please utilize the chat feature to the left, just like the rest of the TASC and Center webinars, to help maintain audio clarity during the webinar. All phone lines are muted by default, and *2 will unmute your line. I don't believe I have any more introductory comments than that. Terry Hill from the center is on the line and helping with the collaborative. The transition to value is one of Terry's passions. So I asked, and he was gracious enough to join and hang out with us for the Learning Collaborative. Terry, do you have anything to add before I kick it over to Shannon to start?
No, that's a good introduction. You know, what we can see by the feedback from you about your knowledge is that most of you are somewhat familiar, perhaps, of these payment models, and I think the basic premise is that, and I think this is coming both from tax and from the Federal Office of Rural Health Policy, is that our payment systems are pretty much moving into value and population health payments. So we think it's very important not to be experts about these value models, but at least to be able to kind of recognize them, know a little bit about them, and also be able to answer questions in regard to if there, if your hospitals have any questions as well. So this will be anything Shannon or I or Caleb have to say that we'll try not to use a ton of acronyms, but anything that you have that you want more explanation of, you can either do that on this call or feel free to call or just email Caleb, and I will be happy to answer questions or be happy to connect you in with other resources as well. Thanks, Caleb.
Yeah, absolutely. Thank you, Terry. And that reminded me of something else, that this learning collaborative is intentionally around a dozen participants, a dozen flex coordinators. That's why when the email went out, we intentionally kept it small so we can have a very intimate place and format. So Robert and Trent from Texas can get to know Kyle from Wyoming and Catherine from Wisconsin. So please don't hesitate to speak up and ask questions and engage in a conversation. And you'll get the feeling that there's a lot to learn on this, and there really is, and that's why we're doing this topic again this year after doing it last year. But that's okay. We're here to learn, and we don't want to terrify you into not speaking and not learning. So please come and enjoy and participate and engage. I have nothing more for preliminary stuff, so Andy, if you want to load up Shannon's slides, and Shannon, if you want to take it away, I will be quiet for a little while.
Awesome, and thank you both, Caleb and Terry, for that nice introduction. And hello, everyone, and welcome to this series of webinars. As I said, I'm Shannon Calhoun. I am from Texas, so that's the accent that you're hearing. I am really excited about getting to talk about this topic, so if I get a little overexcited, just let me know. What I want you to know is that I very much feel that this topic is of great importance at this time of change, and I'm going to try to take it at a high level and then continue to build on that over the next 6 webinars. So, and Caleb, I believe, do I need to go back through this? The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving health care in rural communities. A nation's leading technical assistance and knowledge center in rural health. The center focuses on 5 core areas: transition to value and population health, which, by the way, is what we're going to talk about a lot. Collaboration and partnership is actually part of the success of that, so we'll touch on that, as well as performance improvement. There is a bit of conversation in health information technology, but not a lot. And we'll talk about tooling the existing workforce that you have in the series. So hopefully this will be helpful to you across all of those intentions of the center. So in context of today and the rest of the series, what I want you to know is that I intend to help build a dialogue for you that's custom to you and your state, to have conversations about practice transformation, or I should say payment and delivery transformation or payment and delivery reform in your state. So what I would like to do week after week is just talk a little bit about how we're going to do outreach to that, create a little actionable item, and then continue to build on that so that at the end of the series you really have a comfort level in conversing about what the state of affairs is in your state regarding healthcare transformation for critical access hospitals and rural health clinics. I'll spend some time in different components of understanding healthcare transformation, and that includes Medicare's intention, what that looks like from commercial payers, the difference between payment reform and delivery reform, and then sustainability tactics to sort of tie all that together. So that's a lot, and what we'll do is have good conversations in these webinars, but at the end we'll also try to connect you or point you to the tools and resources, a lot of which are already in the center's library, but we'll make sure that you have connections for all that so you have resources after the webinar. The other thing, I'll briefly go through the preview of the webinar series, but I will speak sort of in topics, and I'll try to pause in between each of the topics, and there's maybe only 3 of them, in case you want to pause and clarify for any questions. So either, just hold your hand up when I say I'm at the end, and you want to ask a question about anything I've said, or go ahead and fill the chat box in, and then Caleb, if you'll let me know if there's someone waiting on that particular topic, I would appreciate it.
Absolutely.
Thank you so much. So I'll go over the webinar series in just a minute, but today I'll also want to cover what started this, why are we here today? So looking at the drivers of healthcare transformation, then talking about the foundation that Medicare built their plan on, and then how they're going to implement it. And then we'll talk a bit about value-based payments. That could get really muddy pretty quick. So I'll give an example to apply the foundations to so you can sort of understand it. And then over time, maybe we'll talk more about it. But right now, I really want to give you the fundamentals. I'm also in every webinar trying to clarify what I've seen in the field over talking to hundreds of hospitals and thousands of physicians literally in the last 5 years about this topic, what the impact on rural health is. So hopefully we can cover all that today, and I'll keep it moving. So the series is Healthcare Transformation. That's a high-level look at really what's happening in payment and delivery reform. The second one will be what is the premier leader of transformation, and that's primary care. They use that in the terms of population health, and so how can we actually use population health through primary care to help grow the care in a rural community? We'll also talk about practice transformation. So what does that look like in a workflow process, and then what tools and resources can you use there? I'll speak specifically to hierarchical condition categories and try to say that 3 times. The short term in acronyms is HCC coding, but it's very important, and it is really important for all of rural to demonstrate the quality of the work you do through this diagnosis coding. So we'll talk a little bit about that. And then if things go right, I would like to really talk about return on investments, and my goal is to build the conversation with you to see if there's important things that we could do to put a little math to it to help you give your folks in your state some support on what that looks like if they're going to make the change. And then finally, I want to tie that back up into how this really affects rurals overall in the long term and in the short term. And so that's the big picture results matter. So that's what we're going to talk about over the course of 6 weeks. Did I just skip a line? Yeah, so the pre-work I would like you to do for the next one is, if you don't already have a comfort level, reach out to some hospitals and see if you can find 5 that are doing some part of value-based contracts, Medicare or otherwise, and if they would agree to let you just communicate with them on specific questions that we ask over the next 5 or 6 weeks. And that will help us build information to do maybe a little bit of a workshop on that ROI piece that we're looking at. So that would really be the homework, is to find someone that you think you could send a question or 2 on a weekly basis and get some response. And we'll check in at the beginning of the next one and then see how everybody did, and then we'll go from there to see what we can do with that information. So with that, what I'd like to do is really talk to you about how we got here. And as you all know, Medicare is really the largest single payer in the world, and payer as an insurance. And there was one really advent that has been being watched for the last 20 years, and that is the entrance of baby boomers into the Medicare population, which changes the curve of cost, total spend to Medicare exponentially once the boomers enter, and they are at the process now of entering into this. This is 20 years ago we heard, oh, we're going to break Medicare, we're going to break Social Security, and we're at that point now where that is a real concern. So I'll dive in a little bit about how that came to pass and how legislation really was affected by this entrance of the baby boomers. I think the other thing, and this isn't exclusive to Medicare, but it sort of sets the tone for what they're really looking for, and their intention is to bend the cost curve, and what that means is the escalation of increase, the exponential amount of increase of people participating within the Medicare program. If everything remains the same, there won't be enough funds to do that, and I'll show you that in just a few minutes. What also is the underlying thing is that any payer really isn't looking at what your cost is exclusively. They're looking how your cost affects the total spend on a per beneficiary basis. So what that means is if Caleb goes to the doctor with his health plan, but he goes out of the network or he goes to 10 other doctors, they want to know what 10 Caleb's on an average spend from the payer side, not the provider side. So the average spend in the country is about $13,000. The lowest in the country is about $7,000. This is on Medicare rolls. And the intention is to change that to less. It's not to change the $13,000 to the $7,000, but to actually just address enough change that it slows the curve of growth in the culture that it's in at whatever that number's in. And we'll talk more about that too as we go along. So this is a little graphic that actually shows you what was driving this. If we look in 2007, Medicare was below 5% of the GDP. In 2027, will be over 10%. Just to note against this, the developing nations in the world are well under, for all care, under that number. The U.S. compared to in the world is 18% of gross domestic product against other developing nations as 11% against gross domestic product. We are an expensive healthcare delivery system. And so that's sort of an underlying math that makes them think that they can make the change. And so you can see that we are doubling in cost by 2029, 2030. It is some by the, this orange is actually the escalation of the entrance into the baby boomers. And then there is excessive cost, which is utilization by preventable admissions or inappropriate duplication of services. And so then you can see what the effect of that excess cost is over time. It becomes untenable for Medicare. What's interesting also is that this actually launched under the Accountable Care Act. And as you know, there was two parts of the Accountable Care Act, that about commercial insurance in general, and then there was the CMS side, so Medicare and Medicaid side. That side of the Accountable Care Act was undisputed on both sides. And the reality is that curve that's bending high would actually take away spend from Congress people to do all of the things that they want to do in Congress. So they're in agreement, and that's how the this program called MACRA, or the Medicare Access and CHIP Reauthorization Act. So this act is not going away. There's really no discussion about anybody changing it. When they talk about changing the ACA, they're talking about the other side of the house and not this particular side. So MACRA, which I'm going to use because if I say it the long way a long time, I might not get there, but MACRA was the Medicare Access and CHIP Reauthorization Act. It did three really important things, and the first one was stop the doc fix. And just briefly, if any of you have been in healthcare long enough and around fee-for-service clinics, or those that are traditional Medicare and not rural health clinics that get paid on an all-inclusive rate. The DocFix is actually a reference to the Medicare physician fee schedule under a fee-for-service model. And that fee schedule has been sort of ignored for almost 16 years because it was too hot of a topic for Congress to deal with. And they put a thing on top of it called a sustainable growth rate, which matched any increases to no greater than what the increase in GDP was on any given year. So MACRA stopped that program. It said, that's not helping the doctors at all. We're going to stop that and come up with something else that talks about increases for physicians, which was pretty historical. And then second, they developed what's called the QPP, or the Quality Payment Program, which is the implementation side of the MACRA program or legislation. And QPP actually did two things. It created two important things. Again, more acronyms, so I apologize, and maybe we'll create a little dictionary for you to have of these acronyms. But the Merit-Based Incentive Payment System, also known as MIPS, is a measurement of cost and quality of anyone that is billing fee-for-service, unless they're in the alternative payment model. And so what you need to know about this program is that when I said that it stopped the DocFix, the only way any provider is going to get an increase in pay is either through one of these two models in the future going forward. And I think that is a really important thing to remember all through this webinar series. If we're going to help them increase, even to the point of an inflation rate, they have to enter into one of these two types of categories, because Medicare isn't talking about changing that. Now, I will say, and Terry, you can chime in if you need to, we did hear some really great information from Seema Verma and Tom Morris at the NRHA conference 2 weeks ago, and they alluded to some things coming to support rural, but they did not back off of the idea that they're going to measure on cost and quality of providers, any providers moving forward. So we'll talk about that in future webinars as well. This is a reference slide for you. I'm not going to dive a whole lot into it, but what I would want you to know is that this really talks about what I've just laid the foundation for. Did someone have a comment?
Yeah, so there's a question whether or not that applies to critical access hospitals, or is it just the outpatient providers?
So the DocFix is about any Part B billing. So when we talked about the Merit-Based Incentive Payment System, if you think about it all the way to the beginning, when I said that we'll talk about primary care and how's that the leader, they're really looking at ambulatory services as the change maker. So right now they're not talking about inpatient services or costs or reimbursement changing. Haven't seen anything about that. So this is really referencing physician fee schedules. Now, there has not been a notice about any change in the all-inclusive rate. My sense, again, Terry, if you want to chime in about this, but my sense is that right now it feels like that the designations that CAH and RHC enjoy are considered an alternative payment model. Nobody said that to me, but they haven't made it easy for you to participate otherwise, and they're not considering, they have exempt you to some degree, and we'll talk about the value of being exempt or not, and that's actually in this program. So they're not requiring any changes in the payment methodology you have today.
Yeah, Shannon, let me jump in here as well.
Please.
Yeah, we have no evidence that our critical access hospital funding is in immediate jeopardy. I think even the hospital leaders in the critical access hospitals, though, are coming to realize that it may be dangerous to stay out of these models. The reason is partially because if they stay in an old model, their value, just in terms of the entire healthcare system, their value to the bigger, remember, part of their value right now is that they send a lot of patients into big hospitals, but under the new value and population health formula, having a lot of patients in your hospital is no longer financially advantageous. That's just a remarkable shift. And those of you that are, like myself, old public health folks, this is wonderful. We're moving to a public health model, guys. And our rural hospitals, even if they're currently not compelled to do it because they're being thrown into these new value models, really need to prepare for them. That doesn't mean they need to get into an ACO necessarily or anything else here, but they need to be able to show their value. It's like our MBQIP data. They've got to be able to show that they collect quality data, even though they're not absolutely compelled to do it. They should be showing it. And so that's part of the message I know Shannon's going to get into as well. You don't necessarily have to move at this moment, but if you don't start moving, you may very well be in trouble on a long-term basis.
Right. So thank you, Terry, for that. And that actually adds to some of my notes that I had in regard to this slide. And without reading it, what I would like to say is the shift is pretty much a significant shift in the delivery system across the board, regardless of where the patient is, and the payment reform is also across the board. It may not be directly, and the point is it may not be directly negative to you, but if there is no positive, what is the result? So it's shifting from overall in the purpose of curing the disease to keeping people healthy. That's the population health model that Terry alluded to. It is also changing in value from diagnosis, treatment, and cure to actually talking and paying for prevention and wellness. And actually, that's a good thing. What I see, the numbers are that a lot of critical access hospitals that have rural health clinics are 75% ambulatory anyway. You're probably ahead of the game in being able to do really well at that. And then the method change will be from fee-for-service, which you're out of to some degree on your clinic side, but it's moving towards value payment, and we'll talk a little bit more about that. So I just wanted to say that there's a shift across the payment reform and a shift across the delivery reform, and they're directly tied to the point of being curing disease to keeping people healthy, from being silos of providers to being patient-centric in giving the care. So all of that should tie together over all the slides that we talk about. One of the things that Medicare put out was a foundation of how they're going to implement this QPP program, the Quality Payment Program. And so it has 4 basic pillars. One is provider accountability and innovation. So what they're doing right now is actually pushing out different types of payment methodologies to see who engages and who is successful in it. And in that, they weave into provider accountability. In other words, knowing how you affect the total cost and quality of any patient going anywhere. And that's for any type of provider. So that provider accountability starts spreading beyond just you being measured alone, because your measurement could affect others in a payment program. The second one is that they want all of the programs that they're pushing forward to be impactful on payments on cost and payments on cost and quality of performance. They want impacts on both of those things. So everything is tied to cost and quality. They also want to see system delivery integration, and the good news for all of you is that you already are a virtually integrated delivery system. In some form or fashion, you see rural hospitals either owning the rural health clinics or having really great integrated solutions and connections with the providers that are in their community. And then you generally have good communications with your referral partners. So they're working to see that be a little cleaner, give you some actual greater opportunities to do that within legal protections of some of the alternative payment models. And then they also have the ability to help support and pay you for that coordination of care and systems. So, and then finally, it's patient-centered care. Like what I just said, it's really about an individual patient within a defined population. So how does that actually translate to what you're going to do, or what does that look like? And from a big picture nationally, I love this slide. It's probably 3 or 4 years old, but what you can see, and if it's too small, I'll explain what all these say. These are the 4 pillars on the left, and this graph is the current state, probably starting in 2012 or 2014. And you can see this orange bubble is actually fee-for-service with no link to quality. It is very transactional in care. The patient shows up, you treat them, they go home, you file a claim and get paid. And there's no connection to getting paid, to do outreach, to do follow-up. It's transactional and reactive in care. And there's no measurement of cost or quality in that. And as you see, moving to the right of the graph, there is a type of fee-for-service with a link to quality and value, and then actual alternative payment models built on fee-for-service architecture, and then you see actual population-based payments. The future state, you see that there's a nice spread of choices to fit where it might work for you well, but there is little left on this fee-for-service with no link to quality or value. So that's Medicare's intention. Just from hearing them speak, I think rural is probably still sitting over here, but they don't define it out like that. So it's interesting to see how they're moving people forward in the alternative payment models. So this is yet another graph that what I want you to know in the next couple of slides is that the rising concern about not participating in alternative payment models is that it is difficult to even become successful in getting any increase in pay or any inclusion in even a cost of living allowance in the payment methodology unless you are moving into reporting to MIPS and scoring and or getting into an alternative payment model. And the example of this is, again, for small measurements of those, this gray bar is actually risk-bearing, which means that they assume they get to share in the savings or in the losses. So that means that they're actually taking downside risk, and we can talk about that if you have questions about that. But the point is you would owe money back if you're in an alternative payment model if you don't do well. People don't need to get in this unless they know what they're doing, but people that know what they're doing, that have been spending time doing this, they have a great opportunity to do a lot of growth for their physicians on their fee schedule. If they're in an alternative payment model, an integrated delivery network, both of these are integrated delivery networks, that do not take any risk, even in an alternative payment model, they're not going to do as well as the ones that are taking risk. And that's intentional. That is, the program is written that way. And I'll show you an example of that in a minute. I said that MACRA, the Medicare Authorization and Medicare Access and CHIP Reauthorization Act, created 2 programs, MIPS and alternative payment models. If you choose not to be in an alternative payment model and you are not exempt from MIPS, then you are subject to the MIPS measurement. And the MIPS measurements measure you on cost and quality. You report on quality. And the funding is from a finite amount of money in a pool. And so this bell curve moves to the right every year. It's not like if you get to the right, you get to stay over there. Every year it moves. For those of you that aren't familiar with the MIPS program, if you have physicians that are billing over $90,000 in Part B, you could be subject to MIPS. And I won't go into detail about that. There's so many nuances to that. There's a place to go online, and I'll give that link to you. I'm going to make a note for that, a link of if you're subject to MIPS, where you just put in the TIN and it'll tell you whether you're subject to it or not. But the point here is that this pool on the left-hand side actually has MIPS and those that are in non-risk-bearing alternative payment models. But those in alternative payment models, whether they are risk-bearing or not, they receive claims data that give them the ability to have a predicted, actionable piece of information to help them have high enough scores that get them to the right-hand side. When you're in MIPS, and that's again an intention for Medicare to drive you to the point of seeing the value of alternative payment models. So you could be in here, but the penalties are going to go to the left-hand side, and the rewards and incentives are going to go to the right-hand side of the bell curve. That's going to change every year. So that basically you're in an alternative payment model whether you are electing to do in the alternative ones, because you're still getting measured on cost and quality under MIPS. They just don't call it a payment model because you're still on fee-for-service. So here's the result, and I'm going to give credit. This actually came from Caravan Health, which is the leading ACO that enabler that does rural health ACOs. I got permission to use this slide, and what you should see here is that this actually shows what happens in actual 2017 merit-based incentive payment system scores. So the small practices that were not in an alternative payment model, average score was 43. Rural practices in a non-alternative payment model practice scored 43. You're doing really well by yourself over here. All non-APM participants, including small, rural, and large, all average about 66. Look at the difference of any one of these than if you're in an alternative payment model. You have information in claims data, and you have the ability to see the information, take action on it, and see where there are gaps that you can address in order to get better scores. So that is a big piece of information about how Medicare is embedding their intention in everything that they're doing. What's interesting to compare is when the 2022 cost scoring average comes into play, and that is because of the acceleration of participation into the alternative payment models and what happens in the pools. The gap is going to tend to become greater because it will become harder. They have so much ability to polish under an APM. They have so much ability to have data. When you're in only merit-based incentive payment system, you are measured on cost, but you have no way to affect cost. So, and that weight changes in 2022. So again, the opportunity is stacked against you. And I think Tracy had a question that says, what does risk or not doing well look like on the ground? Tracy, I think that truly means that how you are documenting, addressing gaps in care, and doing those processes that that demonstrate you have processes in place to take care of the population. It's interesting to see that when we were in the field and people were doing annual wellness visits, which, by the way, is basically a survey that can be done. Now, I'm going to say this with some trepidation because it's a little different in a rural health clinic, so there's a sidebar conversation with this, but just looking at it in the fee-for-service clinic side, if you did an annual wellness visit, does not have to be done by a physician. It's a 40-minute survey of the person's health. It gives the ability to do, I mean, what doctor has 45 minutes to spend with a patient and not do diagnosis and treatment? So it's very hard to do in a small practice, but you're not getting those early detection pieces of information, and you're not demonstrating to any payer on a claim that you have, in fact, put those processes in place that you're measuring what the care of the patient is. Remember, this is going to the point of saying that we're going to go to prevention and wellness. And the way they're going to measure the value is that we have those processes in place. So that's kind of what it looks like on the ground. Doing better in documentation, and then throwing a couple of other things in. And we'll talk more about that in just a few minutes. You're prompting me well. So the short end of the story is an alternative payment model. And I'm going to pause for a minute. Anybody else have any questions? If you do, go to the chat box or raise your hand. For the most part, I just talked about the overall program of all those acronyms, the QPP, the Quality Payment Program, the Merit-Based Incentive Payment System, and the alternative payment models. That is the legislation and the implementation of that legislation that gets us to the point of talking about alternative payment models. So the short end of the story is an alternative payment model is a way in which to get measured on high cost and quality of a defined population. It's an agreement with Medicare, and that agreement could change the existing payment methodology. It might stay on top of your existing plus an additional payment, or it might replace your existing payment methodology completely. So in short, it's a measurement of cost and quality of a defined population with a change in your fee schedule. There's some rules that go along with that. And so this sort of gets a little complex, and I'm not going to go too much in detail unless you have a lot of questions. The alternative payment model, I just described it. Alternative payment models can include providers that are subject to MIPS. There are two types of alternative payment models. There are those that don't take downside risk and or include folks that are reporting under the merit-based incentive payment model. And there are markers that define whether or not a provider is subject to having to report. And generally, if they are in an APM not taking downside risk, they're going to still be subject to MIPS. The good news is that they're reporting MIPS and they're participating in an APM, they're going to have more information and more support on their reporting of those measures. And then there are advanced APMs, and there are basically tracks now that are called basic and enhanced, and all of them eventually move to risk-bearing. Enhanced are a lot more complicated, and no one would suggest anyone take any kind of risk without first getting into an alternative payment model. That is because there's a lot of data to comb through. There is a lot of requirements in order to learn how to be successful in the data game, so to speak. And so Medicare has built in that most of the programs also have a way to start without risk to be able to learn, and then decide if you want to go to the point of risk or actually stop being in the alternative payment model. So I'm going to give a talk through of an example of an alternative payment model. And Medicare had a subset called the Medicare Shared Savings Program. And so you can see yet another acronym, the Medicare Shared Savings Program, MSSP. And under the MSSP, you are required to form an organization that is what negotiates with Medicare. So it would be a tax ID number. And under that tax ID number, it should represent a minimum of a certain number of attributed lives. It's never 100% of the Medicare beneficiaries that you treat, because it's measured on the plurality of primary care given to any one patient. So generally, rule of thumb in a rural community going into an ACO, that's about 50% of your Medicare lives are first attributed. So it's a formation of an organization with no less than 5,000 lives, and it can go up from there, but that was the baseline. And then there is a measurement of cost and quality, and if the quality goes up and the cost goes down, then Medicare will split the savings with you. So for example, if two hospitals got together, they had 10,000 Medicare beneficiaries, so 5,000 got them to the minimum, And under that 5,000, the average benchmark, remember I talked about the benchmark. So the total average spend that Medicare spends on those 10,000 patients, whether they go to you or they go to some urban hospital, they're considered attributed if they got their primary care with you. So if they're those 5,000 that are attributed and your 10,000 was the beginning of the year benchmark, at the end of the year, if you moved it to 9,500, Medicare would split that with you, $500, $250 to them, and $250 to you times 5,000. So that's the shared savings. Patients are not in the ACO. The providers are in this measurement program with an opportunity for incentive. You still treat everybody the same, and in fact, the more you treat the patients, the more data you get on them to actually move them to the point of attribution and protect them from the service bleeding out of your community. You also get this claims data, so every patient that you've touched in Medicare once, whether they're attributed or not, you get the claims data of every place they've been, not just the data you produce. One of the interesting metrics that we saw in probably 2017 ACOs was that some really great financial advisors were participating in the ACO program, and they did a study of how much percentage of Medicare services that the rural communities thought they had 100% as their patients. Probably 30% of even those patients that you think are yours go outside of the rural community for that type of care. And you don't even know what it is, or if you could be serving it, you have no way of getting that information because you can't get that claims data without legal protection of Stark and antitrust and being in this type of organization. So, so I see, did you say an ACO is a subset of Medicare or a subset of an APM? An ACO is a type of an alternative payment model. There are other types of alternative payment models, and I'll send you to a link that it talks about the type of alternative payment models. They do a great job on the website. It's actually a separate website from CMS.gov. It's actually QPP.gov, and it will describe more of that, or we can talk more about it. I see Tracy asked about...
There's a question just above that, too. How would this system pay for providers in comparison with RVUs?
I see that. Okay. So it's interesting. One of the things that is expected shift in this is that your contracts would ultimately need to be tied to value-based payments and value-based participation. So we could do a whole seminar just on what does that look like, but at the end of the day, for example, if you were going to do, you probably, well, if you do any kind of population health service that a nurse could do in conjunction with, by working under a physician, that would still generate RVUs for that physician. That's a short answer that would probably give you a lot more questions, but we can talk more about that, or we can roll that into our one of our last two to make sure that we talk about how to manage RVUs in the big picture. Does that sound okay? Great. Appreciate that, Catherine. Quality goes up and cost goes down, and they split the savings. Now, that's under the MSSP type of ACO, and those probably won't be around forever, but they are still here now, and it's a great opportunity if you can manage dealing with the infrastructure, which is a pretty difficult task. So I somehow skipped through that. Okay, so I wanted to make sure that, sorry, I have a lag time, and I'm going fast back and forth. The one other thing that's interesting on this type of APM is that you're seeing Medicare now recognizing that synergies of what you're doing works better when you do it with other payers, so it's similar to what, so you get to treat all your patients the same regardless of who the payer is. And so there are some opportunities in the advanced APMs that are called all payer or other payer options, and that sort of gives you some credit. Again, that's a long ways down the road from actually talking about what you can do in MIPS or just being really successful in demonstrating your quality through your claim submissions. And we will talk more about that in further webinars. I mentioned, and I want to say one more time again, I've said for a long time, the huge gift of an ACO is two basic things. You get information of a type of market share that you couldn't get otherwise, having claims data of where your patients are going. You may have really healthy people in your community that are going to get wellness visits from a well-woman center and not coming to your rural health clinic. You don't know that, but you can engage in patients and talk to them about coming to you, and you can have information to see how you might want to build on that as an opportunity. And then you have the legal protection of looking at that data and actually having conversations with who you're referring to, saying, look, the cost is going up because you're duplicating my test. And when you duplicate my test, that overexposes my patient for no reason. So let's get together and figure out what your need is, or I'm going to find somebody else. You can't do that at this point without having legal protection that's offered in this type of organization that's produced just to be able to be in an ACO. So that's a very high level of APMs, and we can dig more into that in probably webinar 5 or 6. What I wanted to walk away with you today, and we're moving along on time. I wanted to give you some reasons that I saw in the field of why people feel that they don't want to participate in either MIPS or APMs. And the first one is that they feel because they're exempt that they really don't need to. The result is that if they are not engaging and every payer is following Medicare, and a lot of your Medicaid is moving over to Medicaid managed care organizations and it's falling off your cost report and you're not able to negotiate, or if you're getting Medicare Advantage and that's changing off of your cost report and you're not being able to do that, you're eroding on your platform that's been the primary revenue to something that you need to be able to demonstrate your value to, and if you're not, you're falling behind. So that they're exempt has been probably the biggest concern I see in the field. The second one is it's difficult. My other favorite term is living under the tyranny of small numbers. It's very hard to do this without collaboration. If you can't get that high volume, then you can't create your ACO on your own, so you have to figure out how to manage that with somebody else. There are ACO conveners in the field. They help manage the cost of infrastructure down to a per beneficiary basis, but not everybody's ready for that. So because you're not meeting patient volume and you can't dip your toe in without this bigger lift, it makes it really difficult. The rule of thumb in the country to start an ACO is about $1 million a year, and then after that it's still probably close to that to manage it annually. It's a 5-year contract, so you can dilute that cost by having partners, multiple other providers going along with you, but it's still a high cost even at that. So high cost to build the infrastructure, and there is a cost associated with engaging in this if they haven't done work before. The other thing is that if you choose not to be in the program, the whole macro program, it's not designed for low volume, and rurals are great. Rural people, rural communities, rural schools, rural infrastructure are really great at collaboration, and it's going to require collaboration to be able to get to understand that total spend in order to have empirical data, enough data that makes enough sense to make it actionable. So that's a difficulty. One of the things I was very encouraged about was when we heard Seema Verma speak last week or 2 weeks ago. She actually mentioned something about collaborative coalitions, and there's going to be, I think, future support. Haven't seen it in writing yet, but it's alluded to in all the NQIC or this next round of supporting type of Medicare contractors, that there is collaborative coalitions. Rural do collaborative coalitions really great. So I see some good opportunity, but it is a separate body of work that will be added on. So those rural networks are going to be really valuable in the future. Hard to do without, I think. And then the second one is rural all-inclusive rate and actual, for a long time, accounting firms and EMR systems really only requested or allowed that you put 4 items on a claim for diagnosis and treatment. And that was the minimum, and it didn't matter if you put a lot or a little, and some even had some pressures that felt like it was upcoding. So we only put four things of documentation on that claim. The reality is, if you are not diagnosing the disease state through the hierarchical condition category coding, it is not showing the disease state. And we have never been incentivized or paid to do this type of coding, so there's not been a lot of training in the field to do that. I do come across some that do that, and it's great, but it's not been really a need or necessity because there's not really an incentive to do it when you're getting paid on the all-inclusive. Here's the thing. In the future, with all your commercial payers, if you are going to get paid on how sick your patients are and how much resource you're needed to take care of that sick patient, and you're documenting that this is a diabetic, but you're not putting that it's a diabetic with neuropathy, when you are actually treating them for neuropathy, you're going to lose money. So the way we've been doing it before is not aligning with the amount of resources required for the disease state that you are treating. I kind of feel like that's a result why sometimes they say rural isn't as sick. I think there was a report that said rural isn't as sick and we're not of high quality. We just haven't been incentivized to document properly. And I think getting the documentation in is going to be a huge turnaround for demonstrating your quality in the future. So that's kind of something that makes the hair stand on my head. Then the last one is downside risk is an interesting thing to have a conversation with a political subdivision or those taxing district hospitals. It's difficult. I've tried that before. I've had some conversations with rural hospitals before, and it's an interesting discussion. So that's the last barrier that I had on my list was those 5. So I think that's about it, are my top 5 reasons why I think that rurals are not participating or engaging, the barriers for them to engage. I guess the one thing that I think is the biggest effect is I don't see any other way to grow but through this program that Medicare has. We have to somehow demonstrate our quality in order to have, and our value, our quality and our value in order to get new types of payments. And I felt like that I heard that both in Tom Morris and Seema Verma and the things they alluded to but that are not out there, but they're still holding fast to this program model that is a measurement of cost and quality for everybody that's a Medicare provider. And then the other thing is, even now, all payers are looking at this. All payers, so all commercial entities are considering cost and quality, and they're looking at public information. 5 years ago, I ran across Blue Cross Blue Shield in Texas, and they said, we're going to do this Blue Ribbon Network. And the Blue Ribbon Network was taking all publicly available data, and then everybody that met the, checked the box for this publicly available data like Leapfrog and NCQA and those types of things that rural providers generally don't have infrastructure or need to do. They put them in this Blue Ribbon Network, and then rather than trying to get you to move to that new network by negotiating, they just offer the Blue Ribbon Network with a product to a customer that's already Blue Ribbon, Blue Cross, and say, if you select the people in the Blue Ribbon Network, we'll give you a reduction in your copay. Just totally bypass you completely. The point is, commercial payers, if they see no value in you, they're going to work around you. I spoke to a Medicare Advantage plan that's a friend and said, so, what are you doing for rurals? And she said, well, if we can't get rurals into the quality metrics, we're going to work with Lyft for Life, which is like the Uber in the rural communities, that they'll actually put MAs in the field to pick up the patient, drive them to the place where they are of high quality, presumed high quality, and then treat them and drive them home. It's of concern that we are being perceived with a negative score, or not even submitting a score creates us look like a negative score that has low quality. By doing nothing, it's a perception. So I think that's the biggest effect that I see in the field, is that we need very desperately to do something that demonstrates high quality in rural communities. We all know they're good, but we need to be able to demonstrate that on their terms. So with that, I probably have, I'm over 1 minute. I'm willing to hang around if anybody else wants to talk. I apologize. I told you I'd get excited.
No problem. So I appreciate the questions that we've been seeing in the chat feature. We're a little out of time, but anyone who's interested in sticking around a little bit or has the opportunity to stick around a little bit, *2 will unmute your line. Go ahead and ask some questions. And if you do not have an opportunity to stick around, email me your questions, put them in the chat or the forum in the SharePoint page, or type them into the chat box now as you log out, and we'll get some discussion happening outside of the webinar.
I'll try to help chime in with you on that, Caleb, if we keep a list of questions that come in between now and next week, and then we can answer them at the beginning of the next one, or we'll publish them where you said the information will be.
Yeah, absolutely. And in the meantime, if we don't have any questions now, I will get the slides as well as the webinar recording posted to the SharePoint page. So everyone has an opportunity to review those, and as questions come up, please go ahead and either email me, email Shannon, post them into the external SharePoint page, and we'll have an opportunity to review those between now and our next webinar, which is a week from now. So we'll just meet every Wednesday at 2 Central between now and the middle of June, or however, the end of June. I think it's 6 weeks. Yeah, so thank you very much to everyone who took the time. Jody, I will connect with you offline to make sure you have access to it. You should have received a couple emails from Jesse from the center. Catherine, you and I will connect as well. So yeah, and if you don't have access, please send me an email, because those come from another department and are generated by the website once you get invited to join. So I can't verify that you got those other than hearing that you didn't get those. And we do have a question, Shannon, if you're there, to discuss the downside risk, and can I clarify that a little bit?
Right. So the easy analogy for that is, remember we talked about if you had $10,000 as a total average spend across a pool, and if you create savings down to $9,500, Medicare would split that 50-50. So if you went to $10,500, you're going to have to pay $250 back to Medicare. So it's just the opposite, but you pay back instead of receive shared savings. That's upside risk. Hopefully that makes sense. And I don't see any rural providers doing that at this point. You really need to be really versed at what your total spend is, how you can manage your spend with your networks, and that takes a lot of time, especially with low volume. That's really hard to do. And then I see Angie has, what would be some specific recommendations relative to this stated challenge? All future programs favor those accepting risk, but downside risk may not be approved by rural boards. I think the very first thing is demonstrating your quality. Right now, you don't need to miss the opportunity of any type of payer, and if they're measuring you on quality, start measuring. When you feel like you're comfortable, you can voluntarily report. You just need to start measuring. You need to understand and start measuring.
Yeah, and I think getting one of the ways to address that, all future programs favor those accepting risk, and demonstrating to the earlier slide that almost all future payment mechanisms are going to this type of system. Now's the time to join where there is no actual, there is no risk.
Correct.
Does that make sense? You're getting to learn with a safety net of if it does end up costing more, then it's not harming, you know, my financial bottom end, then at least no harm, no foul.
Right, right, right. And there's some encouraging things that happen when you engage in chronic care management and even doing the annual wellness visits. Even if you're billing all-inclusive rates, there's good results in that for your community as well as for your outpatient services. And so one of the things we'll talk about in the population health webinar is to talk about how that increases growth in your clinics for service demand and as well as patients and being able to bill for services. So I think that there's some positive things that come out of participating in that other than just reporting. You just need to know, as a learning exercise, you need to know where you can win outside of the traditional way you're getting paid for right now. You're not going to know until you start measuring. I really appreciate everyone's interest and questions. Thank you.
Yeah, and again, as you think about it a little bit between now and next Wednesday,